So thank you everyone for attending. I'd like to welcome Dr. Raja Reddy, who's a friend and a colleague. He's a consultant anaesthetist at Medway Hospital. He's also the president of the World Association of Pain, and he provides his expertise with pain management for both pre-op and post-op pain in patients. And he's here to talk us about non-operative management of degenerative joint disorder. I'd like to thank Professor Amit Tolat, who's the current president of BIOS, who's co-chairing this session, as well as Ortho TV Online for broadcasting this worldwide. For any questions, please put it in the chat box, and then we will try and answer as we go along, or if there's specific to Dr. Reddy, then we'll do it towards the end of the session. Thank you, Raja.
Right. Thank you, Amit and Bijay, and good morning to all the delegates on an early Sunday morning from here in UK. And I'll be talking about non-operative management of degenerative joint disorders. I'd done a similar talk at the BIOS meeting where it was labeled radiofrequency sensory denervation of the major joints. But I think we've tweaked this a little bit to get in more trainees as well as consultants. So as Bijay introduced, I'm Dr. Reddy. I'm a consultant anaesthetist and pain physician at Medway. I'm also a certified interventional pain sonologist and educational supervisor for pain management fellowship programs here. I wear other caps as well, as Bijay said, but let me talk you through these slides and this talk now. So the objectives of this presentation is mainly to understand the non-surgical options available for patients with knee and hip osteoarthritis. And for this, we need to understand the sensory innervation of the knee and the hip, especially the articular nerve supplying the anterior capsule of both of them, although I will talk a bit of the posterior capsule as well. And then to identify targets, both under ultrasound and fluoroscopy. And also we'll discuss available evidence and the outcomes from these evidence. And finally, the complications and adverse effect of all the options available for these joint disorders. A little bit about the epidemiology. Based on evidence and many articles, we still know that symptomatic knee OA is present in approximately 20 to 30% of all population aged more than 65 years. And also the lifetime risk of developing this is estimated approximately 45%. And given the increasing life expectancy and high BMI, I think the prevalence of knee OA is only going to increase in the coming future. So we need to be prepared. Now, I think blessed are those who have advanced severe symptomatic osteoarthritis because there is a definitive management plan, and that is arthroplasty, whether it's hip or knees. And this was confirmed in the National Joint Registry, where we do approximately 100,000 of them. And then in the PROM study, where the patients are so happy with the hips and knee replacement. But again, approximately 15 to 20% of the patients can still have post-knee or post-hip pain in spite of normal biochemistry and normal imaging. So I think we have to look into that as well. Right. So for patients with non-surgical options, who are these patients? Arthroplasty is not an appropriate option. And what will be the circumstances? It could be mild to moderate OA, extremes of age, it's a very young patient with moderate osteoarthritis, or very elderly patient with too many comorbidities where it's not appropriate for surgical options, very high BMI. Now each zone, even in around Southeast England, has got different BMIs, wherein the cutoff target might be 40, but a few orthopedic surgeons whom I know have said in their personal opinion that even with BMI of 45, their outcomes, their personal experience has been good. But I think that's a very limiting option, the high BMI. And the other thing is the lifespan of the implant. I mean, I know we got more than 10 or 15 years now, but then again, you need to plan it in such a way. And revision surgery, wherein both the surgeon and the patient might be reluctant to have multiple revisions. So these are the indications wherein we need to explore non-arthroplasty options. So what's the other group? It's not acceptable to the patient. There are few patients who don't want to take the risks associated with arthroplasty, and therefore it's not available. It's not an option for them. And the third group of patients will be post-arthroplasty pain. Now, as I mentioned in my previous slide, approximately 20% will still have chronic pain in spite of normal biochemistry and normal imaging. There's no loosening of the implant. There is no signs of infection, but they'll still have hip and knee pain. And this is approximately, as I mentioned, 20%. And there are other reasons as well. One of the reasons is very simple to treat. If it is a localized neuromas, you can identify them and treat them. Second one will be implant failure, as I mentioned. Third one is infection. Finally is the central sensitization. It's not exactly CRPS, but the features are such that it's not infection, but very sensitive areas. Under those indications, we try not to intervene with the knee, but we try to target the dorsal root ganglion of L2 and L3 supplying the knee. I'll speak about that later. And so what is the mechanism for persistent pain following arthroplasty? I always ask the audience, or the audience asks me, what is the mechanism of pain relief following arthroplasty? Then I mention it could be surgical debulking, denovation. But then the audience asks, but sir, cartilage doesn't have any nerve supply. They are right. So it is a neural structure. So loss of joint space doesn't mean anything unless the subchondral bone is exposed. Probably that is why there could be some loss of joint space, but then they're asymptomatic without any pain, because I think the nociceptors are not exposed to the chemical irritation, etc. So I think in my next series of lecture, which Vijay and me have been planning, we'll be talking about nociception in osteoarthritis. Therefore, the nociceptive structures are usually the joint capsule, the synovium, and the subchondral bone, and it is never the cartilage. So that's one of the mechanisms we talk about persistent pain after surgical denervation. And also, after any surgical operation, the healing process involves neovascularization. New blood vessels are formed, and usually the nerves follow the blood vessels. As a result, the normal neural architecture is lost because of the new onset, the new blood vessels, and there are many more nerves around. That is why some of the knees or the hips become very sensitive, because where there was 10 free nerve endings, now you've got 25, 30 free nerve endings. Therefore, the mechanism of allodynia, hyperalgesia, or increased sensitivity. So this is a very challenging topic, persistent pain after arthroplasty. Finally, there are a few systems where there's a huge waiting list for arthroplasty, like in our NHS system, and wherein alternate options can buy them time till they're ready to have a definitive treatment like a replacement. That's what I've mentioned. Okay, let's move on to the next slide. Right, so what are the non-surgical options? One is weight loss, as I mentioned, because BMI is a very important factor. Second one is lifestyle changes, whether it is smoking or exercise, etc. And weight loss, and there's evidence for this as well, especially for physical therapies. I'll come to the next one. Now, can you see this? There's moderate evidence that any weight loss in a patient with body mass index greater than 25 is not associated with a good outcome. Finally, the second one will be physical therapies. Now, physical therapies, they're not exactly a cure, but what it helps with the core strengthening of the muscles around the knee joint. And most important thing, what we've seen with the physical therapies is improved proprioception. And this leads to less falls. that is why I think it remains the core of initial management of patient with osteoarthritis. Then what are we left with? Medications. There's a combination of treatments available in terms of medication. One is, we all know, anti-inflammatory medications and non-steroidals do help in pain in terms of osteoarthritis. But in further slides, I will show that we've seen an improvement in pain, but not exactly function, and it comes with its own side effects, renal side effects, gastrointestinal side effects. Therefore, we need to exercise caution of using anti-inflammatories, especially in elderly patients, because there's evidence it increases the blood pressure, it impairs renal function in diabetes. So even a single dose is enough for them to go into failure. So we need to be very careful, and some surgeons still believe, and I too as well, that can it impair bone healing. Therefore, anti-inflammatories should be judged in which patients to give. And what are the other options are intra-articular steroids and intra-articular hyaluronic acid. Now, intra-articular hyaluronic acid is still popular, although the available evidence did not provide any positive outcomes, but it's still quite a prevalent practice. And so is corticosteroids with benefit up to probably 3 months, which I will speak about in the future. And finally, the new kid on the block, platelet-rich plasma. We just had 2 articles released this month, which I'll be speaking about the evidence available for PRP. What are the other options? I've spoken about all of these. Right. In terms of lifestyle changes, you would have heard about the ADAPT trial, where exercise and dietary weight loss in overweight patients undergoing knee osteoarthritis. So what did the ADAPT trial come across? According to them, even after 18 months, despite only a moderate reduction in body weight, there was significant improvement both in pain and function in this diet and exercise group. So it sort of reinforces the fact that exercise and weight loss are strong indicators for patients with better to improve outcomes. And there was another randomized controlled trial about the treatment of choice for knee osteoarthritis. And here we have weight reduction of 10% improved the function by approximately 28%. And there was another previous old study about the Birmingham study where 800 women showed a decrease in BMI, though this was little flawed in terms of the statistics. It showed a decrease in BMI of greater than 2 kilograms per meter square in the preceding 10 years and decreased symptomatic OA by 50%. And I think there were lots of critics with this paper. Right, still some more papers on exercise and physical therapies. And this was another network meta-analysis study wherein a combined intervention of strengthening, flexibility, and aerobic exercises were more effective than no exercise. So as this is the very important thing in terms of physical exercises. The enhanced proprioception may reduce risks of fall, and that goes a long way in helping the patients. Next, we're coming to pharmacological treatment. A little more talk on this. Now, if you see the chronic pain classification, we subdivide it into somatic pain and neuropathic pain. Now, the best example of somatic pain is nociceptive pain, which is osteoarthritis. Now, the best example of neuropathic pain would be CRPS, which we all know. And there's another subset where there is both nociceptive pain as well as neuropathic pain, and that will be your sciatica, radicular pain, because there's a disc is inflamed and also the nerve is temporarily injured. So they always asked whether osteoarthritis has got neuropathic pain components. Yes, there is, based on a few papers and based on also the pathological mechanism, but primarily it is an inflammatory pathogenesis. Even if the subchondral bone is exposed, unless those nerves are traumatically cut, wherein the patient will get sort of features of pins and needle sensations, allodynia, hyperalgesia, only then you can label it as a neuropathic pain, or mostly it will be anti-inflammatory pain only. That is why it's very few studies have used anti-neuropathic medications like gabapentin, pregabalin for the management of osteoarthritis, because it is labeled as nociceptive and inflammatory pain only. Right. Let's see what evidence we have in terms of non-steroidal anti-inflammatories. We have both highly selective COX-2 inhibitors as well as your traditional anti-inflammatories like diclofenac, etc. And here it is not advocated the long-term use based on the side effects what I've mentioned. And these are all the three major side effects: gastrointestinal, cardiovascular, and renal. And what are the other analgesia? Opiates. Now, opiates has got some mechanism of action for anti-inflammatory mechanism as well. But the problem with the opiate comes with the long-term use of opiates, including tolerance, number two, addiction, then we have withdrawal. And finally, there is this concept of opioid-induced hyperalgesia. Over a period of time, the mechanism is such that these opiates don't provide the pain relief, and so it's not a consistent treatment for patients with OA. And also when they've seen the NNT, numbers needed to harm for this was 5 compared to placebo. Therefore, I think we are still in a very gray area, and especially with the opioid epidemic in North America, where oxycodone pills were given like mints, you see. And now they're fighting that battle by trying to replace opiate with the cannabinoid, because there's a common ligand and receptors. I think probably in the near future, we'll be looking at cannabinoids as an alternative to opiates for osteoarthritis as well. Right, what's the other ones what we use? Viscose supplements. This is very popular, at least in our region. It is used in the primary care centers by even musculoskeletal practitioners, and in a few centers here as well. Now, there have been lots of studies, systemic review, meta-analysis, another systemic review. What one of them was involving almost 12,000 patients, and they compared it with sham, and the duration was greater than 3 months, and it was a clinically irrelevant benefit. And the maximum benefit, they said, was an improvement in pain, but no change in function. And look, one of our primary outcomes of any treatments, what we provide is improvement in pain, but we also need secondary gains or secondary outcome, whether there's an improvement in sleep, improvement in mobility, improvement in quality of life. So I think that is where viscose supplement probably falls short of that. Intra-Articular corticosteroids. Now, this is a very popular treatment. For decades it's been used, and there have been quite a few studies with mixed results. But then again, not everyone is interested in the long-term outcome of all studies. They want to know, how will I treat my patient for the next 6 weeks or 12 weeks? How can I give them short-term pain relief? But there you go. So this was one of the RCTs of IA steroids for osteoarthritis of the knee, double-blind, placebo-controlled, 2,000 patients, and they compared almost 24 weeks after the injection, and there was lack of evidence both on pain and function. Another randomized controlled trial, prospective double-blind, three groups. There was no difference between any of these groups, whether the patient had steroid or Hyalase or saline, and up to almost 100 patients. And this was, remember, this was for the hip osteoarthritis. But then again, it's still in practice. So I'll leave it for you all to consider these treatment option. Now, this very interesting paper on conservative management of symptomatic knee osteoarthritis being a very flawed strategy. And this was, these were the findings from that paper about, I mentioned about chronic opiate consumption, non-steroidal anti-inflammatory. And this was a very interesting thing about viscose supplementation. following up to 13 weeks. And what they found was a clinically irrelevant benefit. And how did they come to this conclusion? They were measuring the pain scores, which was less than 0.1 on a 10 centimeter visual analog scale. Finally, the other one was the corticosteroids, where I mentioned earlier. They've seen an improvement in pain, but not an improvement in function. And again, that didn't last more than 4 weeks. Now, here is the new kid on the block, platelet-rich plasma. This is a separate topic by itself, and you all know there are different types of platelet-rich plasma, different variations, and there are almost 30 different types of system: platelet-rich plasma, platelet-pooled plasma. The idea is such that we take 20 mils of a patient's blood, which has got approximately 100 or 50, 100,000 platelets. You spin it and you get concentrated platelets, approximately 500,000 to 1 million in a few mils of plasma. And these platelets contain activated growth factors, which helps in repair. The trick is when to inject the PRP as well. So, but based on any evidence, this is what we got. Lack of satisfactory conventional treatment options. It greatly outpaced the evidence, whatever work we are doing. And there was one paper which, here it is, editorial this month, platelet-rich plasma for OA and Achilles tendonitis. Meaning we had strong evidence for almost most tendinopathies, including plantar fasciitis. And even with OA, the evidence was reasonable well for knee compared to the hip. And what they've done is they compared 3 RCTs of PRP, including knee, ankle, and Achilles. And here is what they suggest. It's not yielded a successful new therapy. Until a new generation of trials, it would be prudent to pause the PRP for OA and Achilles tendonitis. This is a paper for discussion by itself. I think we should discuss this at a later date. And here's another one, the Restore trial, where the randomized trial, 288 adults, 50 years or more, where they compared with the knee osteoarthritis with PRP and a placebo. And in this case, it was normal saline. And what did they find? Intra-Articular PRP compared with saline did not result in a significant difference in symptoms or joint structures at 12 months. So they do not support the use of PRP for knee OA. Even if you look at the NICE guidance for PRP in knee osteoarthritis, they got some papers, but they've exercised caution. They've also recommended use of using your local governance team if you want to undertake any research or audit regarding PRP. There we go. But I like PRP. So finally, what are the other options available? And here it is, which we as pain physicians do quite often, called as radiofrequency sensory denervation of joints. That's only half the treatment. The remaining half is articular branches of the anterior capsule of the knee joint. And it is also should be called as partial sensory denervation because we never touch the posterior capsule, either of the hip or the knee, as the same with arthroplasty. But then again, we are not. I was asked this question again, as if you target the posterior capsule as well, what will you lose? Now, the posterior capsule, as I said, does contain nociception. Therefore, there'll be an element of a pain, which should be there in any joint replacements. But then proprioception is not because of the cartilage or the capsule. Proprioception mostly comes from your muscle spindle and the tendon attachments. Therefore, proprioception won't be lost in arthroplasty. So that's what I wanted to highlight that. So there are quite a few studies. It's very early days. There's a bit of evidence available for both hips and knees, mostly for the knee, very little for the hips. And the evidence is starting to emerge for shoulder as well, for post replacement and other surgical diagnosis of the shoulder. Right. So what do you mean by radiofrequency ablation? We apply indirect current. It causes coagulation, necrosis of the tissues. But then again, how do you know you're targeting those nerves? You can argue that you're burning the periosteum. So what happens is we do sensory testing. At 50 hertz, it captures the sensory nerves. And then we check the voltage, at what voltage the patient experiences pain or reproduce the same pain. It should be ideally approximately around 0.5. That means you're very close to the proximity of the nerve. And then we change the frequency from 50 hertz to 2 hertz to capture the motor nerves, meaning we don't want to be in the vicinity of any motor nerve, whether it's a hip or a knee, more so with the hip joint because of close femoral nerve, etc. So we make sure that there is no twitch either of the quadriceps or the hamstrings, and we rule out burning the motor nerve. So it's exclusively we are sort of denervating or ablating the articular branches of the joints. Here is the mechanism. So 80 degrees centigrade, it causes coagulation, necrosis, and natural denaturation. And therefore, the signaling is lost. But if sometimes we have to do a mixed spinal nerve, especially for the shoulder, like the suprascapular nerve, we change the whole settings, and it is called as a pulse radiofrequency, wherein the temperature is reduced to 42 degrees centigrade. And the mechanism is not coagulation necrosis. The mechanism is different. What it does is it impairs conduction by acting on the neurotransmitters, etc. So this is, we call this as, this is called as, in a pain physician's term, we call this pulse as microwave, and this as barbecue. That's for the articular nerves. This is for the mixed spinal nerves. Right. So what are the electrodes we use? The bigger the size, it's better for us because we need to split those nerves apart. So we use different terminologies, like we use 16 gauge as well. Active tip can be either 5 millimeters exposed or 10 millimeters exposed tip. And we also used to inject some saline to increase the lesion size. And there's a monopolar lesions, bipolar lesions, and cooled RF. Cooled RF means we increase the size of the lesion even more. And now the latest one is called as the multi-tined RFA. It's like this. So it goes in and then it opens up to cover all the joints, and you get the lesion of this size. And this is the experiment to see how big the lesion is. This is very helpful, especially for knee RF, because the nerves come from posterior to anterior at right angles. And these newer equipment captures them better. So let's understand something about the innervation of the knee joint. And here I'm talking about the anterior capsule, and we call it as genicular nerves, genu knee. But then there's an argument says, do genicular nerves actually exist, or the terminology should be changed to nerves accompanying the genicular blood vessels, which I fully agree. So in terms of that, we usually identify 3 major genicular nerves supplying the anterior capsule. That will be your superior medial, superior lateral, inferior medial. Although there are other genicular nerves as well. Why we identify these 3 is because they are anatomically consistent, and they almost cover 90% of the supply of the knee joint. The other knee joints would also include the inferolateral bit, then there's an intermediate, and also there's a recurrent, which we need not. One thing we always try to avoid is the inferolateral. The reason we avoid inferolateral is the articular branches are very close to the common peroneal, and therefore there have been instances of foot drop when they've tried to do the common peroneal denervation. Therefore, and also it's not anatomically consistent. So as long as we remember superomedial, superolateral, inferior-medial. And most of the research have targeted these 3 nerves for denervation, as it is here in this picture. And this was the quite a few studies which has been done trying to study the innervation of the knee. Let me go back to this slide. Now, if you see these genicular nerves, so where are the nerves coming from? So it's a combination from the femoral nerve with branches from the vastus medialis, vastus lateralis, vastus intermedius, which all have got articular supply as well. More so the vastus medialis, also called as the retinacular nerve. And then also there's branches from the posterior division of the obturator and from the infrapatellar branch of the saphenous, as well as branches from the common peroneal and posterior tibium. So all these form the popliteal plexus, and they come from posterior to anterior right angles, usually at the junction of the shaft and the condyles of the femur and the tibia. So this is a summary of the studies, of all the anatomical studies to identify all these branches, what I mentioned about. From 1948, they've been studying, and still even 2021, we've had a few studies. But what we have found is usually the superomedial, the inferior-medial, and the superolateral. These are the three more consistent features, with branches from all of these, including the saphenous. Now, I think I've just tried to capture some latest literature on nerve supply to the knee, where they've, this was one study where they classified it into 4 quadrants: superolateral, superomedial, inferior-medial, and superomedial. And here was another study where they studied the innervation of the anterior capsule of the human knee. And they've identified all the 6 branches, what I talked about. And there was this conclusion. Here it is: the inferolateral peroneal lobe branch was found to be too close to the common peroneal nerve. Therefore, it was inappropriate. So what I have done is, here is I've identified, this is my idea of a knee joint facing you. So this will be the medial, this will be the lateral, and here is your superomedial, superolateral, inferior-medial. These are the 3 consistent features. And then there's also nerve to vastus medialis, and we try to avoid this. So it goes in line with this, what I was trying to prove. And this is how we do at a workplace. Recently, we've done a retrospective analysis of the last 3 years of doing the knees and hips, approximately 56 patients of knee, very few for the hip. It was only 4. And what we did was we did both primary outcome, secondary outcome. It was done in combination with the orthopedic registrar and the pain registrars as well. They found significant improvement, almost up to 50% for these patients. And one patient had relief for approximately 3 years. But then again, these numbers were small. And what we plan to do is have a database so that we can capture all the data and do it on a more of a prospective studies as well. Here is all the needles in place. And remember, we use a combination of both ultrasound and fluoroscopy. This is a hybrid procedure. So on the ultrasound, we try to identify the genicular blood vessel, place the needle, and then with fluoroscopy, we do both a AP view and a lateral view. And then this is the radiofrequency machine, where it will sense both sensory, motor, and then we can adjust the temperature to burn those articular nerves. So for the fluoroscopy targets, where exactly are these targets? Now, initially, when the studies came up, they all were of the opinion that is at the junction of the condyles and the shaft, the metaphysis there, and then it has to be midway through the depth of the bone. And here is all the targets they mentioned: superolateral, superomedial, inferior-medial. But then we had another study where they showed actually the nerves are more distal, almost at the level of the condyles, the articular nerves where they transit, and therefore we had to change the whole targets for us to move it in terms of capturing and burning them. And here is the lateral view of these joints as to show where exactly these are. And those are the targets, what I mentioned. Right. Now, so we also need to do this under ultrasound. Now we place the ultrasound in a biplanar, meaning it has to be done both in a longitudinal and in a transverse fashion. In a longitudinal fashion, you see the slope. That is the shaft, and then the condyles are coming into view, and at that junction you see the genicular blood vessel and the nerve, and then we do a transverse view and then place a needle and then confirm with fluoroscopy. Same thing on this side, same thing on this side. So each denervation takes approximately 1 hour. This is a major problem when we have post-arthroplasty knee pain, because you don't get to see one blood vessel, you get to see multiple blood vessels, you get to see multiple nerves. So when we use this approach for post-arthroplasty knee pain, we have struggled because there is more than one nerve, and the treatment is not as good as what you call it as a virgin knee. But this is one of the options where the results are good, but not as brilliant as a non-operative knee. Right. This was the first ever study which came up in almost 10 years ago, where they did a randomized control trial, placebo-controlled in elderly patients with severe knee osteoarthritis, and they've targeted those 3 branches what I mentioned about. This is an AP view, this is a lateral view, and they did both primary outcomes, secondary outcome measures, including Oxford knee scores, improvement in quality of life, and up to 12 weeks, more than 50% pain relief. And this was a very few get sham controlled trials because it's very difficult to get ethical approval, but they did it. And this kickstarted the whole non-surgical option, meaning radiofrequency ablation as a treatment option. And these are the, what I call it, the markers what kickstarted the whole show. And following that, yeah, some of the papers I would like to present in terms of the RF options. So this was a multi-center randomized. It is not a sham. I don't think any other country approved that. Therefore, to prevent that, what they do is a crossover. Therefore, ethically, it is, I think it is quite meaningful as well, rather than do a sham control. Crossover trials are the way forward. And in this case, they compared radiofrequency with corticosteroid injections in the management of knee pain osteoarthritis. Here it was 151 subjects, and they compared knee pain, knee scores, and also the functional scores, and up to 6 months after the interventions. So what did we get? The radiofrequency had more favorable outcomes compared to your corticosteroids, with greater than 50% pain relief, improvement in Oxford scores, and there was no procedure-related adverse effects even with either any of these procedures. So this was, there were very few papers trying to compare RFA with steroids, especially high-quality paper. And then this was another paper where they compared radiofrequency. This was very interesting. They compared hyaluronic acid this time along with the radiofrequency. This was again multicentric RCT, and what did we have? 182 patients who had radiofrequency of 4 genicular nerves, not 3, and they compared again pain and quality of life, and compared it at 1 month, 3 months, and 6 months after treatment. And what did we have? Improvement was better with the RFA group compared with the steroid, with the hyaluronic group, and also improvement in function with the WOMAC score was better in the RFA group compared to the hyaluronic acid. And this was another study. In this case, they compared PRP with the radiofrequency ablation. This was a single-blinded RCT. 200 patients with osteoarthritis were equally distributed into 2 groups, and one had a pulsed RF, meaning they had only 42 degrees centigrade, not the 80, 60 or 80 what I mentioned about, and the other group had the PRP. And they compared at 3 months, 6 and 12 months. The pain score was significantly lower in the PRF group compared to the PRP, and also the incidence of OA with the PR group was less in terms of pain and other values at 12 months follow-up. So this was from Orthopedic Surgery Academy, JM Journal. What they said was a very good systematic literature review where they compared radiofrequency as a non-surgical treatment for knee osteoarthritis. What did they find is when they compared with steroids, compared with hyaluronic acid, RFA provided improvement in pain, function, visual scores, all of them which I mentioned. And also it was quite safe. Did not have any adverse effects related to the radiofrequency ablation. Is it safe? I've kept telling that there's not been any major side effects. Based on this, it is possible there's a risk of genicular nerve can cause sort of a pseudo aneurysms or aneurysm, but it's very few documentation in literature. And as I said, there have been a few reports, and this was the previous one where 9 RCTs did not show any adverse effects at all. But there have been isolated cases of tendon injury, hematoma, infection, and a skin burn. Right, that was little about the knee RF I spoke about. And then let's talk about the hip joint and the articular nerve supply in the hip joint. Now, I mentioned here again, I had a discussion with a few of the orthopedic trainees when I was doing a theatre list for Bijay about articulation of the hip and the knee. I told them that we never ever touch the posterior articulation, posterior articular nerves or the capsule, posterior capsule of the nerve joints. It's always been the anterior capsule what we target. For the simple reason we don't want to end up in a situation like Charcot's joint where there is no sensation at all. And I think it's the same thing with arthroplasty. Most of the time, I think there's a little bit of the posterior capsule left intact. Right, sensory innovation of the hip joint again was as early as 1948, where the nerve supply is only 2 nerves supplying the anterior capsule. This is your femoral nerve coming from the superolateral compartment, and then from the inferior medial through the obturator foramina, we have the obturator joint, supplying the hip joint. So these two remain the hallmark of all the nerves supplying the anterior capsule. Few can come up from higher up, few branches open up at the lower down. Same thing with this. But we need to be very careful because we are very close to the obturator foramen in there. And this was another study again, showing the same about the articular nerve supply of the anterior capsule of the hip joint, the femoral branches, and the obturator branches. These guys also described the posterior capsule of the hip joint, which can be seen under ultrasound, usually, the superior gluteal nerve, as well as the nerve to the quadratus femoris supplying the hip joint. But we avoid, and there are many reasons why they say they avoid based on literature. One thing I mentioned was we don't want to take away all the innervation. And there's also one of the papers mentioning there's very important circulation coming from the posterior aspect of the femur, so around the joint, especially collateral circulation. And they say not to burn or do any interference there. I've captured one of the recent studies where they were showing all the articular nerves supplying the hip joint. Here we have your the articular branches of the femoral nerve, and also there was the obturator nerve, and also they have now this called as the accessory obturator nerve, AON, found in almost quite a few subjects. But look, important thing is these landmarks. So for the femoral high or low, it's always been the iliopubic eminence or the acetabulum. I will show you in my next slide, both the ultrasound as well as the fluoroscopy targets. And for the obturator nerve, it is the teardrop appearance or the incisura where we target. Here it is, anterior capsule. This is the fluoroscopy target. The iliopubic eminence, the suprapubis there, and here is your target for the posterior, the inferior-medial, where we access the operator nerves as it comes out from the foramina. And what we've done with this, yes, this is for the posterior capsule. This is the AP view, and this is the target. And there are different approaches how to. It's very challenging approaching the operator nerve articular supply. So either you can come from lateral to medial or becoming inframedial straight, but this will be the targets. And you have to do a series of lesions because the nerves come from here and supply the joint, you see. So one is not enough, especially the operator. So we do a series of denovations here. And this was a CT study wherein the needle was introduced between the artery and the nerve to target the operator nerve branches. Right. So if you're doing an ultrasound, there are two ways what we do: AIS, and the suprapubic eminence. So what we get to see is there's the AIS, then anterior inferior iliac point, and there is the target. This is the psoas bursa there, but that was initially described for that. But here is the suprapubic eminence for the femoral nerve articular branches supplying here. But the other option is to do it from this side, meaning when I do a hip joint injections, when you place the probe like that, you get to see the neck of the femur. That's the anterior capsule, that's your femur, then there's your acetabulum there, and that is where is going to be the target for one of the articular branches. And then you come down for the operator, and then you get to see this one, just the acetabulum, and that's your target. So you do a combination of both fluoroscopy and ultrasound. And do we have any enough studies for this? Yes. Very early in 2001, where they targeted sensory branches of both the operator and the femoral nerve for treatment of hip joint, 50% pain relief for almost 80% of the patients, but they used a single diagnostic blocks. But then again, we feel it shouldn't be called as a diagnostic block, it should be called as a prognostic block, because we don't block all the nerves supplying the hip joint, because there's always a sparing from the posterior capsule. And this was another, this was more of an observational study where they used both ultrasound and fluoroscopy to target that's your femoral branches, and this was the operator branches. And what they found was improvement in pain function following RF ablation, and up to close to a year. And those are the things. Right. This was another interesting study. This was in 2021, this year. This is called as radiofrequency sensory partial denervation. This is what we call it as. This is how it should be defined with any articular branches: anterior capsular articular branches, sensory partial denervation. And what they found, 9 observational studies, both prospective, retrospective. The most common outcome measure was pain relief, and they used fluoroscopy. They targeted both the branches, and what they found was excellent outcomes in terms of pain relief as well. Here it is. Up to their follow-up duration was up to 3 years, and what they found was this: significant pain up to 6 months, and long-term outcomes as well. There was only one study, longest pain relief up to 36 months, though it was not quantified. Now, so this was, is this practice safe? So this was all the topic about. What we said was, there's been cases, especially since the hip has got more neurovascular structures compared to the knee, especially around the hip joint, especially the femoral nerve in close proximity. And there was adverse events with this procedure. And mostly, as I mentioned, it is usually both the femoral nerve and the distal branches of the obturator. Paresthesia was most common. If it is simple neuropraxia, we call it as bruising of the nerve. It just heals between 3 to 6 months. But then again, if you want to do nerve conduction studies, Either do it immediate or you wait 4 to 6 weeks, because it needs to complete all the histological changes, including Valerian, degeneration, etc. If you want to plan it, it's a nerve graft or muscle graft or this one, whatever treatment you want to do. Quadriceps femoral neuropathy was the most severe. Yeah, that's what we've seen as well in the study. And why we don't do posterior denervation of the hip joint, this is why. We don't want to do, this was, I think, a very old paper. You'll have lack of joint stability, and also it's like bone on bone, and they'll have frequent falls, etc. So that's one of the reasons I found this paper. It says never do posterior denervation as well as anterior. You'll end up with these joints. Now, there was lots of topic I needed to talk about, including the same articular branches and evidence available for shoulder joint as well in the same setting. But there's so much new information coming, and I thought it will be too much to take in at one sitting. I'll speak to both Amit and Vijay and see if we can do it at a later date. But I conclude saying that based on available evidence, in carefully selected patients with hip and knee osteoarthritis, sensory denervation of the articular branches involving the anterior capsule can provide a safe alternative treatment option. There in my talk, and thank you everybody for listening, and thank you Amit and Vijay again.
Hi, Raja, thank you. Yeah, thank you, Raja. Excellent comprehensive talk. Vijay, do you want to
Raja, can you stop sharing so we will come on the things? Yeah.
I've got one or two to ask Raja as well.
Why don't you start, Amit?
Yeah.
Okay. So
Raja, stop sharing the screen so we can.
Yeah, stop sharing it so we can open it up. So
okay, got it. Yeah, got it.
Okay. So Raja, first of all, I must congratulate you on a very comprehensive and timely, I would say, talk, particularly when you're talking to surgeons, isn't it? That there is so much of non-operative management of these conditions as well. So what I wanted to ask you was, you mentioned obviously a lot of the non-operative methods, but one of the things I wanted to ask you was that a lot of patients do have what are called pain patches, like buprenorphine, for example. And
I can't hear you.
Can you hear me?
I can hear you, Amit.
Yeah, I'm not
on
mute. Can you hear me now? Can you hear me?
I can't hear you, Amit.
Raja, can you hear me?
I can hear you, Vijay, not Amit.
Oh, that's a bit odd.
Okay, you try and sort it out, Amit. I've got a couple of questions.
Okay.
Raja, is there again, in an amazing talk, and I know as orthopods, people get concerned about, oh, is he going to impact on what I do? And you quite clearly made it obvious that, you're not talking about doing this treatment in the group of patients where arthroplasty has been shown that it works very well. You have shown that these are alternatives in patients who you don't want to do replacement for a variety of reasons, as well as in ones who have pain after the arthroplasty. So a couple of questions from me. Is there any nice guidance on this at all? First one. And the second one is, if you have to repeat them, when do you repeat them?
Okay. Can you hear me?
Yeah, I can hear you.
Vijay, can you hear me, Vijay?
Yeah, I can. I can hear you, Raja.
Okay. Now, let me answer these questions. Now, most of the indications for these procedures, as I mentioned earlier, will be where it is not an appropriate option or it's too early to intervene, and patient doesn't want arthroplasty or post-arthroplasty. Now, what we've seen so far is the pain relief lasts approximately between 6 to 12 months, because these nerves tend to grow back. It's almost quite impossible to keep them away unless we go with more bigger lesions and, distance them totally so that they don't grow at all. But when they grow, they will produce this thing called as deafferentation pain. Remember, they used to do the trigeminal neuralgia. They used to burn it. And we used to read in books, anesthesia dolorosa. But that was a wrong treatment because they were burning a mixed spinal nerve. And that's why they were getting deafferentation pain. Whereas with the knees and the hips, they are only articular branches. So very little sympathetic or a motor sensory component in this. What we have seen is up to 12 months, I tend to leave them as they are before I tend to redo. And as I said, it buys us time till the patient wants to have a proper whatever treatment as we do with arthroplasty. And I can repeat it as often as I want. But the only thing is we need to capture all the nerves, and I recommend probably twice a year or once a year would be my treatment option for these patients.
Is there any nice guidance?
No nice guidance, Bijay, because it's very early in these, at least when it comes to this. Probably we are trying to, because the evidence, as you've seen, is not as robust as people have produced for, say, osteoarthritis and steroid injections, which seems to have the highest quality of papers. But I'm sure we will get some guidance from these regulatory bodies in UK.
Okay. Amit, can you not talk?
Yeah, can you hear me, guys?
I can hear you.
Yeah. Raja, can you hear me at all?
I can hear you now, Amit.
Ah, you can hear me. Oh, that's good. Excellent. So there is a question in the Q&A box which we need to answer, but just another quick one I wanted to ask you. Well, you didn't hear me before, but I wanted to thank you for a very comprehensive talk and a very timely one for the orthopedic surgeons who are listening in. But what I wanted to ask you was that, we have quite a lot of pain patterning with patients waiting for surgery. So do you think that addressing these problems prior to surgery by effective pain management could reduce some of the negative outcomes? Say, for example, a patient who has knee osteoarthritis for a long period of time waiting for surgery and then has an adverse outcome after the knee replacement because of persistent pain. Do you think that that long-term pain that they had before, if it was addressed effectively, could reduce the adversity of outcome afterwards, subsequently? Hello? Raja, you're muted. You're muted, Raja.
Yeah.
Yeah.
Is it clear now?
Yeah. Did you get my question?
Amit, I think you need to type a question. I can't hear you.
Oh, okay. All right.
Okay.
Can you hear me?
Let me open up my, the speaker volume is max, so I shouldn't have any problem.
You said you could hear me before, so.
Yeah, now I can hear you, Amit.
Okay, all right. Let's make it brief. Do you think that giving effective pain management for people with long-standing, symptoms, say knee osteoarthritis, and then having the operation, so would it mean that their possibilities of having less pain after the surgery would be much better if you effectively manage this preoperatively? Because you see people with knee replacements who don't improve because they have some pain persistent after the surgery as well and never goes away. Did you get that question?
Yeah.
Okay.
Now, most of the patients we get are usually referred by the orthopedic surgeons in the first place. So, and I mentioned in my early slide, if there is any persistent pain after arthroplasty, it is seen by the orthopedic surgeons first. And I think they do all the inflammatory markers, x-rays, cell scan, and they want to rule out both implant failure and infection. And once that is ruled out, then they say, okay, then probably they would consider revision if they think for whatever reason, and then they say, okay, let me refer you to the pain clinic. So that is when we come in to do the needful for post-arthroplasty patients.
Okay, right. Basically, what I was saying was that if they had quite a lot of pain patterning prior to the operation, would effective non-operative management, whether it be radiofrequency, whatever other modalities, reduce that risk of that patient developing the CRPS after the surgery? Do you think that there's any scientific evidence connecting that? Raja, did you get that?
I didn't get it, Amit.
Oh, it's episodic. Okay, right. Let's, BJ, do you want to do the Q&A?
Okay. So Raja, there is a question. What will be
Yes,
the
Vijay.
anticipated complications of radiofrequency? That's one. The second one is, do you get neuroma formation? And how do you manage it?
Can you hear me?
Yes.
Yes, look, insofar in the 5 years or 6 years I've been doing radiofrequency ablation of the knees and the hip joints, so far we have had 0 complications. The trick is to do it both under ultrasound and fluoroscopy. Whatever reports have come is they've not used the dual approach, meaning you would have gone straight with your fluoroscopy only to target especially the hip joint. And that means you got no idea where your femoral nerve will be, or the patient would have been sedated. So that is why femoral neuropathy has been one of the highest incidence of the nerves being affected by this procedure. Therefore, one of the safety features is to identify your blood vessels, place the needle under ultrasound, and then do the target structure. That is one thing. And we also seen that in very high BMI patients, even reaching the target tissue under fluoroscopy can be very difficult. Very difficult. It's taken sometimes more than 1 hour to get into the target areas, both with ultrasound and fluoroscopy. The incidence based on the papers is almost 1% is the reported complications. And it's usually the blood vessels and the nerves of the femoral, and same thing with the knee. With the knee, because we don't do the posterior capsule, so that's very rare incidence of the blood vessels being, being injected or being targeted. But
I think he's got a Wi-Fi problem.
Looks like.
Because it's episodic interconnection and failure. So now he's gone completely frozen. Raja, you're completely frozen. Maybe he can rejoin.
He's coming on.
He's coming back on. Maybe he's just rejoin.
Any other questions, guys? Otherwise, we'll wrap up.
I think so.
Back.
There's in the Q&A. There's only a thanks from one of the attendees, and
Nitish. Mr. Gogi has joined, and Prof. Shetty is here. Good morning, Prof. Shetty.
Hi. No, I'm there.
Nitish is there. Nitish is there.
Yeah.
I think Raja has had some Wi-Fi failure. So it's possible he was having this episodic connection problems. So, but
Yeah.
we could just
No, I
join
think
you both now. It was very comprehensive and
exactly quite complete talk.
And the message was very clear, I think, for everybody in the audience that radiofrequency ablation seems to be having the most promising evidential base to the various treatments that were discussed. But this is obviously a semi-invasive procedure, and there are some risks associated with it, particularly in the hip, as I could make out compared to the knee, where the risks are a bit less. But the hip, perhaps people need to approach radiofrequency with some caution, because that one paper that I saw where they described the risk of quadriceps palsy and various other things happening just does suggest that you've got to take this very carefully because of the vast neurovascular bundle around that.
Yeah, I mean, now,
There you are, Raja.
Yeah, I need
Summarizing some of your talk. Can you hear me as well? No,
I can hear you now. Yeah.
So your Wi-Fi must be the one. Yeah. Okay. Fine. Let's wrap it up quickly now. So, Vijay,
I can answer all the questions now.
Okay. Fine. Do you want to answer this question of mine?
Okay. Go ahead.
The question that I wanted to ask you, there were two of them, but first of all, what's your view on buprenorphine patches, pain patches? Number one, and number two, are there any studies wherein they combine radiofrequency with other modalities, say like intra-articular steroid, hyaluronic, because you're talking of some semi-invasive treatment with radiofrequency? I didn't see any study that's compared the combinations of the two. So say a patient had physical therapy, had intra-articular injection and radiofrequency together, and what was the outcome?
Okay. So in terms of buprenorphine patches, we use these patches for a selective group of patients in whom taking medication is a compliance issue, because these patches last for 7 days and it is waterproof. And remember, these are partial agonists. They're not completely new, like morphine or Roxinam or OxyContin, etc. So we use buprenorphine patches for elderly patients. Number two, for patients who want to come off morphine, because you see, it is when we have difficulty in getting patients off morphine, then we use buprenorphine. Okay. But it is a good option because the addiction with patches is less, because it's a partial agonist compared to a normal morphine medication, what you give.
Yeah, and I would have thought the gastric side effects would be much less as well.
I would say so. No, but it has got a hepatic bypass metabolism as well.
Okay, right.
So keeping all this in mind, the other option is the newer drug called tapentadol. I talked about. Why tramadol is popular in opiate medication is it's got three mechanisms of action. So it's got a partial mu action, and also it's got SNRI, whereas it reuptake inhibitors of noradrenaline and serotonin. Therefore, if the patient has got some neuropathic pain along with the inflammatory pain, the tramadol seems to work better, or the tapentadol seems to work better compared to plain opiates like codeine and morphine. Therefore, it's got two components. It covers both neuropathic and nociceptive pain. So that is one in terms of buprenorphine patch. We are very reluctant to prescribe opiates for patients with arthritis because you have better options than morphine. Number two, there's no studies clubbing together, because I tried to see if there's one paper which is come on it where they've clubbed hyaluronic acid with PRP together.
Okay, right.
And that seems to show good evidence. Can you imagine? Two different mechanisms of action. So I think that's one of the mixed treatments I have seen so far. And now the PRP group is very happy that when you club it with hyaluronic acid, the outcome is better.
Right. Okay.
So very few papers have come, because I think there's a big ethical issue in approving such combination treatments.
I see.
Unless they do a crossover for the other patients, you see. So it's a very complex evidence it'll become. So that is why.
Yeah. No, thank you very much. Thank
No
you
problem.
for that. And an excellent talk today. Thank you.
No problem. Vijay, I can hear you now. Rest of the questions.
Yeah, there aren't any at the moment. That
No,
I can
Vijay
see
is on the
at
in the
moment.
chat.
Vijay,
group.
you're
I've
on
got some.
mute.
Vijay, you're mute.
Sorry.
Vijay,
about
I
the-
can answer them directly rather than questions. If you can read
Okay.
it for me, I can answer them directly.
Yeah, so it was about post-op knee pain, which I
Yeah.
think you covered in your talk anyway, that it's that it is used for knee pain post-op.
No, I'd like
long
to add
as-
something about post-op knee pain, Vijay.
Yeah,
Now, one of the primary outcomes after post-operative knee pain is pain relief. Okay. Secondary outcome is how soon they mobilize, and is there any quadriceps failure and other issues. There's a tertiary outcome as well, that is prevention of chronic pain. Now, to prevent chronic pain, you need to block the primary afferents, the sympathetic chain, and the dorsal root ganglion. Therefore, when you do a central neural blocks, like an epidural or like a spinal, there is an inbuilt mechanism to prevent chronic pain. And if you're doing only GA and a femoral nerve block, or a GA and a sciatic nerve block for knee pain, there's every chance that you're not giving the patient an opportunity to prevent chronic pain. The evidence says, oh, it doesn't matter whether you do GA or spinal, the outcome is the same, but they're not comparing the chronic pain in these patients, you see. Based on my clinical experience, I always tell them, do the initial block, whether it's a spinal, usually a spinal, and then top it up with what you want, rather than do a GA and a nerve block, wherein you might say you're saving time. Post-op, the patients really struggle, and also you get quadriceps failure if you have done the femoral block only. So for post-op knee pain, there is a new thing. We do a spinal, and there is a thing called as an IPAC, wherein the needle is placed between the popliteal blood vessels and the posterior capsule and ultrasound guidance, and there we inject local anesthetic so that it blocks all the popliteal plexus and all the genicular nerves are blocked. Srinivas Samsani wants to do that audit, and we are planning to do it next year. Of course, we'll involve some orthopedic surgeons as well. And that seems to be the current trend compared to the adductor canal block or the femoral block or the sciatic block. No good. The evidence is very poor for post-op knee pain.
thank you, Raja. There's no more questions so far. So I think I would like, on behalf of the university, myself, as well as BIOS, a big thank you for giving up your Sunday morning to provide us with an excellent lecture. Thank you once again. Thank you, everyone.
Thank you, Vijay. Thank you,
Thanks,
Amit.
Auto TV.
Thank you. Thank you, Raja, as well, on behalf of BIOS. Thank you. Bye-bye.
Thank you.